Welcome to another EduMed video, and this video is on airway pressure release ventilation in the series, and we will talk about how to do APRV on anaesthetic machines as opposed to the intensive care ventilators that are usually used for APRV. This is hopefully quite useful in a time where we don't have enough intensive care ventilators and we do have to sometimes use an anaesthetic machine, either on the intensive care or occasionally where we have to transfer a patient for an emergency surgery who is on APRV. So we'll talk a little bit about what APRV is and about the concept of inverse ratio ventilation, and then how to use the anaesthetic machine to set APRV settings that would be used on an intensive care ventilator. Well, it's first of all quite useful to think about what we can set in APRV. And there are only really 5 things that we set in APRV. The first is the fractional inspired oxygen concentration, which is similar for all ventilators. And then the other things are unique to APRV in what they're called. That's the pressure high. This is the pressure at which it's kept at the high pressure. And then the T high, or the time high, is the amount of time that it's kept at that high pressure. The P low, which is usually set to 0 or as close to 0 as possible, is the pressure low. And then the time low is the amount of time that it's kept at that low pressure. What's special about APRV is that the valves are able to open and close very quickly. The T low, or the time low, is usually kept at between 0.3 and 0.6 or 0.7 seconds. That is much quicker than the opening and closing that you would get on a normal anaesthetic machine. So, as much as you can get close to what the ventilators on intensive care do, they are not going to provide exactly the same level of ventilatory support as what a intensive care ventilator does on an anaesthetic machine. Similarly, generally speaking, APRV is done in a spontaneous mode of ventilation. This is very difficult to replicate in patients that you try to do APRV on an anaesthetic machine, because again the valves are not quite as advanced as you get on an intensive care machine. The closest approximation to APRV that you can achieve on an anaesthetic machine is probably inverse ratio ventilation. Generally speaking, in normal breathing, you take about you have a 1 to 1.5 to 2 ratio between inspiration and exhalation. You know that intuitively because when you take a breath in and then you breathe out, generally speaking, your breath out takes a little bit longer than the breath in. In inverse ratio ventilation, what you do is you flip it such that your breath in takes longer than your breath out. And that's what APRV does. You're taking a long time at a high pressure and then a very short time at a low pressure to release the gas out. So if you want to set APRV on an anaesthetic machine, the first thing that you need is to put it into a pressure control mode of ventilation. And you wouldn't usually put pressure support on because patients, if you're putting them on this, generally don't need pressure support, and the ventilator probably isn't good enough to be able to provide pressure support along with the high pressures that they're on, just by virtue of the type of valves that they have. Your P-insp, or the peak inspiratory pressure, is equivalent to your high pressure, or the P-high. Your inspired time, or TI, is then equivalent to your T-high, or the time at the high pressure. Your PEEP would be your low pressure, and your expired time would be your T low, or the time at the low pressure. So, when you're setting up a ventilator, let's say, for example, you look at the left-hand side of this table. You have a patient who's on an APRV setting with a P high of 25 centimeters of water, a T high of 3.5 seconds, a P low of 0, and a T low of 0.5 seconds. So if you wanted to replicate that on an anaesthetic machine, what would you do? Well, we said that the peak high or pi pressure would be the PINSP, or the peak inspiratory pressure, which would be left at 25. The T high is the same as your inspired time, or TI, and that would be 3.5 seconds. Your P low is the same as your end expiratory pressure, so your PEEP, which if it was 0, you'd set it at 0. And then comes the difficulty, your T low. Well, we said that the T low is equivalent to your TI, to your TE, your expired time. But you can't really set that in many ventilators. What you can set, however, is your respiratory rate and I to E ratio. So this is where you need to do a little calculation to be able to work out exactly what you need. So let's say you've got an inspired time of 3.5 seconds. So you can work out what your TE is by working out this little equation. So there are 60 seconds in a minute. So 60 divided by your respiratory rate is going to be equal to your respiratory cycle, the amount of time that you're in inspiration and expiration. So your TI and your TE. So if you rearrange that equation, so you do 60 breaths per minute, and you know that your TI is 3.5 seconds, and you know that you want an expired time of 0.5 seconds, because that's what your T low was. If you rearrange that, you get 15, your respiratory rate of 15. And so therefore, if your respiratory rate is 15, that gives you an I to E ratio of 7 to 1. 3.5 to 0.5 is a 7 to 1 IE ratio. So therefore, with your ventilator, you can set a respiratory rate of 15 breaths per minute and an I to E ratio of close to 7.1 to 1. And that will effectively give you a TE of 0.5 seconds. So you can see that you can pretty much approximate what you're doing with the APRV on an intensive care ventilator onto an anaesthetic machine. But I want to emphasize that inverse ratio ventilation is not the same as APRV. The anaesthetic machines do not have as good a valve to release quickly and to re-close the valve. And therefore, I would avoid TEs, the expired times of less than 0.5. And if the CO2 is rising, I would actually increase the TE, because what you might be finding is that the valve just isn't opening and closing quick enough, and therefore you're just getting accumulation of gas and the bulk flow isn't as good. Also, the anaesthetic machines may not allow spontaneous breathing. Now that might not be a problem for you if the patient is paralysed because they're having surgery, but if you're using the anaesthetic machine in intensive care, be wary, because they may not allow spontaneous breathing. If you do have to start extending out your TE, the other thing that you might need to think about is that if you remember back to your the APRV talks that we gave earlier in this series, the amount of PEEP that you're maintaining isn't set by the pressure low, it is set by the amount of time. And by using a very short time low, i.e. the amount of time that it's at a low pressure, you're maintaining the pressure within the lungs and therefore maintaining recruitment. You lose that as you start to extend your TE. And if the anaesthetic machine valves aren't good enough to give you those very short Ts, you might actually need to set a slightly higher PEEP level to try and maintain some level of recruitment. So the first thing I want to say in the summary is anaesthetic machines are not ITU ventilators. You can't get a like-for-like comparison, but you can get something very close to it with what we went through here. And essentially what you end up with is an inverse ratio ventilation. A really key point is if you're struggling with this in an anaesthetic machine, it is probably wiser to go back to a conventional mode of ventilation like pressure control ventilation with a normal I to E ratio and just adjusting the peak pressures. If you really need it, I would change from an anaesthetic machine to a conventional ITU ventilator, but if not, inverse ratio ventilation might help for some patients, especially if you don't have access to an ITU ventilator. But traditional inverse ratio ventilation is not the same as APRV, so don't conflate the two, but you can get quite a close approximation to it if you want to keep a patient on the same settings whilst they're in theatre, for example, on an anaesthetic machine, or for whatever reason you don't have access to an intensive care ventilator on ITU and need to use an anaesthetic machine. I hope that was useful. Please like and subscribe to this channel and hit the bell notification. There's going to be lots of videos coming out giving guides on intensive care in the next few months. Thank you very much.